Hey guys, this is Kathleen. I'm giving you some updated information on how to kind of pull everything together for anemia. Anemia can be tough. I'm going to review a lot of pathophysiology and bring that into how to diagnose anemia, what to look for in lab results, and give you some case studies on specific patients that I've talked a little bit about in class and talked a little bit on the PowerPoint, but I wanted to add this in for those who are struggling a little bit. And this will be good to have for studying for finals and the boards as well. When we talk about red blood cells, we're talking about erythrocytes. And if you think about the root word, erythro means red and kytosis means hollow. The red blood cell is hollow and bilaterally concave, and it has no nucleus. Actually, this form allows for a larger surface area, and actually this shape helps in the role of the red blood cell when it's picking up and delivering oxygen. Also, 90% of the red blood cell is comprised of hemoglobin. Another way of thinking about this is the red blood cell is hemoglobin with a light coating over it to keep it in place. When we break down hemoglobin, heme is composed mostly of iron, and globin is comprised mostly of protein. Keeping that in mind, the red blood cell, again, is composed mostly of iron and protein. The iron temporarily binds with oxygen in the lungs and releases it throughout the body. But what happens when a person develops anemia? Let's first take a look at anemia. Anemia is not a diagnosis. Instead, it's a complex of many signs and symptoms that are characterized by a decrease in red blood cells and hemoglobin. Anemia could be caused by blood loss, deficient erythropoiesis, or excessive hemolysis, or some combination of those changes, like recent blood loss, deficient erythropoiesis, or excessive hemolysis. Anemia only occurs when the insult to the body is severe enough to disturb normal homeostatic mechanisms which exceed reserves. In other words, our body does an amazing job preventing us from having anemia. Oftentimes in practice, you will have women that present and say, after you're reviewing their labs, oh, don't worry about me being anemic. I'm always anemic. Again, just like I said in class, it is our job to be concerned about their anemia because the body's, again, mechanisms from keeping us from being anemic are really amazing. We go back to pathophysiology. We look at what triggers normal erythropoiesis, and that is oxygen tension. Oxygen tension and renal perfusion, when these are down, this serves as a trigger to stimulate the kidneys to produce erythropoietin. So what triggers erythropoiesis? Again, it's a drop in oxygen tension. This triggers the kidneys to detect that there is a drop in oxygen tension. This drop may be slight or just related to the normal loss of RBC or the normal red blood cells expiring. Erythropoietin is a hormone that commits the stem cell to the red blood cell line. The stem cell has been produced by the bone marrow and is now committed to the red blood cell line. The kidney does release erythropoietin, which is a hormone that commits the stem cell to the red blood cell line. During this process, the liver, which is the main storage point for iron, again, the liver is the main storage point for iron. The liver releases iron that is incorporated into the developing red blood cell, forming hemoglobin. The RBC is produced and poured out to the body to circulation. And the question would be, how long does this process go from stem cell to RBC? And it's about 25 days. The stem cells, upon exposure, proliferate and differentiate to RBCs. And they go from stem cells then about 15 days later, through the influence of erythropoietin, develop into erythroblast, and then iron is added into the formulation. About day 21, they develop into a reticulocyte, and a reticulocyte is a young red blood cell. And when this happens, additional cellular material are inside as well. Over the first few days of reticulocyte circulation, that extra material is cast off by the red blood cells, and by day 25 is circulating mature cell form. So RBC circulates on day 25. RBCs are the largest of 3 cells. They are the most abundant in circulation, and their functions are needed to form a red blood cell. Erythropoietin is a hormone, and it's largely secreted by the kidney. 90% is secreted by the kidney, and about 10% from the liver. Erythropoietin, the hormone supply, diminishes in renal failure, and this basically begins when the GFR is less than 49. Anemia of chronic disease is often seen in renal failure. Also, anemia of chronic disease, in a normal, healthy individual, you need uncompromised DNA synthesis. Chronic inflammation affects DNA synthesis. For examples of people with rheumatoid arthritis, lupus, they have chronic inflammation. So the take home here is to treat that chronic inflammation, and then the RBCs will come back. Also, for hemoglobin synthesis, we need good nutrition. We need B vitamins. They are the cofactors of developing RBCs. We need vitamin C to facilitate iron absorption. We absolutely need adequate absorption. We need iron to go in, but we also need it to be absorbed. We also need intact marrow, bone marrow, microenvironment. One question is to ask yourself, what is the best way to see if the bone marrow is effective? And that basically is to do a bone marrow biopsy. As an NP, a future NP, do you think that is cost effective or clinically needed for those presenting with anemia? Absolutely not. So another way to see if the bone marrow is working is to look at the reticulocyte to determine if the marrow environment is working or not. If someone's healthy, the reticular count should be 1 to 2% of the RBC. If the marrow is not healthy, the retics will not be produced. The ability of the bone marrow to produce RBCs, what is the response of the body if you have anemia? If you have anemia and you're healthy, the body's going to respond with reticulocytosis. It's going to increase those immature small red blood cells in the attempts to correct the anemia. Okay, so let's say that right now you're in the ED setting. You have a young man. I talked a little bit about this in class. I'm going to make this a man because virtually men are not anemic. You have a young man who's 19 years old who has nothing wrong with him other than the fact that he just got into a major MVC and he's fractured his femur. He has no hepatic or splenic laceration and nothing else. When you examine him, his thigh is ecchymotic, swollen, and hard on palpation. Patients who have femur fracture bleed a lot into that compartment. He has lost a few units of blood. You check the retic count in 7 days. In a young, healthy male, the retic count most likely would be 9 to 10%. He has good bone marrow. In a young, healthy body, he can return back to normal fairly quickly. A 72-year-old male who walks into your office, he went to the bathroom this morning and he reports that he filled the toilet twice with bright red blood. This gentleman is having acute lower GI bleed. He's a little bit lightheaded, he's tachycardic, clearly needs to go to the hospital. He has bled down from a hematocrit of 38 to 32%. The blood loss was so quick, it did make him a little hemodynamically unstable. He went to the hospital, got some fluid, and he did not require a transfusion. If you were to check his reticular count, it would be 4%, not 8 to 9% in comparison to the 19-year-old, because he does not have a 19-year-old bone marrow. He has, and this, for his age, is a normal response to anemia, his retic count of 4%. Causes anemia: acute from hemorrhage. Most common reason for a quick, dangerous drop of hemoglobin. You want to make sure you rule out hemorrhage as a reason for anemia. Rule out hemorrhage as a reason for anemia. In an outpatient setting, a history and physical exam are key factors in ruling out hemorrhage as a reason for anemia. You want to interview the patient. For example, you have a woman of childbearing age who comes in and presents with you. She hasn't had a period in 2 months, and she's bleeding heavy from the vaginal area. One more time, history is so important. I am bleeding heavy from the vagina, she reports. This woman most likely is losing her pregnancy. Clearly telling you about what is going on. In an adult, greater than 1 liter loss of blood before you, in an adult, greater than 1 liter. So you can lose up to 1 liter before there is a clinically significant drop in hemoglobin. That's a lot. Most likely cause of sudden dangerous drop in hematocrit or hemoglobin is from bleeding, and this can be caused from erosive gastritis, heavy menses, GI malignancy. Also, you can have clinically significant blood loss that can be as little as a few mLs per day of GI blood loss, which will produce fecal occult blood loss, positive. It will not turn the stool black or tarry. Black tarry stool means upper GI bleeding because the blood has been digested. General rule is it's going to take a couple ounces. Lower GI, usually rectal bright red blood from the rectal area. So causes of anemia: you've reduced RBC production, premature destruction, hemolysis, shortened lifespan. Black tarry stool means upper GI bleed. Low GI bleed is bright red blood. If someone is bleeding 5 mLs per day from a gastric ulcer or carcinoma, person is going to have normal appearing stools, but will have fecal occult test positive. Decreased RBC production: this could be nutritional, vitamin B12 deficiency, folate deficiency, or anemia of chronic disease. Premature red blood cell death destruction. In a healthy adult, the red blood cell lifespan can be up to 90 to 120 days. If the red blood cell lifespan is less than 90 days, this would be considered a premature loss of RBCs and is a reason for anemia of chronic disease. This is seen in anemia of chronic disease, where the RBC do not live as long. Pure hemolysis or hemolytic destruction of RBC is a very uncommon reason for cell destruction. However, if you practice in a sickle cell clinic, that will not be the case. There are exceptions to the rules. So broken up RBCs from a hemolysis is very rare, but if you worked in a sickle cell clinic, you would be seeing a lot of this. Lab work for those who are anemic. Let's go over the meaning of some of the lab work. Hematocrit, RBC cell volume are the same term. So hematocrit and red blood cell volume are the same term. You have hemoglobin, you have red blood cell, RBC. If hematocrit and hemoglobin is drawn, the RBC, if the hematocrit and hemoglobin is down by 1/3, then the RBC should be down by 1/3 as well. Why is the hematocrit also known as packed red blood cell volume? That is literally what it says. It's the packed red blood cells. So in the olden days, we would spin out a tube of blood and see what remained in the bottom and what was left for plasma. What was in the bottom of the tube gave you your hematocrit level. And so red blood cell volume are the same terms as hematocrit. When the hematocrit can be falsely elevated in severe dehydration. Also, if the person is overly hydrated, it can falsely reduce and expanded circulating volumes. So some examples of this: the older adult with urosepsis who comes into the ED and you are evaluating them and they're from a long-term facility. The hemoglobin is 11 and the hematocrit is 39. That's a person who has a falsely elevated hematocrit. Conversely, the pregnant woman in the last trimester, her hematocrit is 32 and her hemoglobin is 12. Increasing circulating volume causes a falsely low hematocrit. Hemoglobin to hematocrit ratio should, in a healthy individual, be 1 to 3. So if the hemoglobin is 10, the hematocrit should be 30. If the hemoglobin is 12, then the hematocrit should be 36. If the hemoglobin is 15, then the hematocrit should be 45. Once again, hematocrit can be falsely elevated in severe dehydration, as well as a person who is overly hydrated. The hematocrit can be falsely reduced in expanding circulating volume. Therefore, most important here is that the hemoglobin is a more reliable number than the hematocrit, because the hematocrit can bounce around a little bit. Let's say I have a patient in my office. He's a 45-year-old man with fatigue. You listen to his history. He's telling you he has poor sleep hygiene. He's stressed. This is a typical scenario. They want to know there must be something wrong with their body, yet they're not eating right, very stressed, and not sleeping more than 4 hours a night. So oftentimes they want to say that, I think I have anemia. Can you rule out anemia? To keep healthcare costs down, most likely you would want to just get a hemoglobin in an otherwise healthy individual. Just get a hemoglobin to rule out anemia. So his hemoglobin is 15.2, and if you can do the math, then his hematocrit should be 48. And basically, I've ruled out anemia. Keep that in mind when you're trying to keep healthcare costs down. Today, a lot of people have health insurance, but their policies are slim, and also there are very large deductibles too. We need to think about being cost effective. Weintraub classification anemia, we're going to talk about RBCs by its size and how to diagnose a normocytic, microcytic, or macrocytic. And that basically is looking at the red blood cell size. Also, we're going to looking at the color, normochromic, chromic meaning color. So when normochromic cells are brightly colored, you have classification anemia macro, micro, and normocytic. Hypochromic, you have an MCHC less than 31. Hypochromic cells are pale. Hypochromic, they have a thin ring of hemoglobin that is very pale. Remember, chromic is color. Red blood cell distribution width, RDW. This is one of the most underappreciated parts of the CBC. It is often ignored because this is a fairly new phenomenon in the last 2 years. Again, RDW is red blood cell volume distribution width. Red blood cells are produced by the body individually by the body. They vary a tiny bit from one another, as much as 11.5 to 15% difference from the smallest to the largest in a normal, healthy individual. And that's an important factor to keep in mind. This is a quantitative report of anocytosis. RBCs are of unequal size and are often found in anemia in anocytosis. This is a hematologic term meaning marked variation in size, anocytosis. When the RDW is abnormal, it is elevated. What that tells you is that the new cells are different size compared to the other cells. This is one of the most reliable markers for deficient erythropoiesis and an evolving macrocytic or microcytic anemia. This will bail you out more times that you can believe, particularly finding an early evolving anemia. An RDW elevated, RDW normal limit, RDW, notice cells are very close to each other. If you Google RDW, these cells are very close to each other in size. Our body makes each cell individually, therefore they will differ, which is very normal. In nature, hardly anything is made in a cookie-cutter pattern. We are marvelously imperfect the way we are put together. Example, one hand is bigger than the other, one foot is bigger or smaller than the other, and RBCs are made imperfectly, and it works. Retic count, most often we are talking about a percentage of retics, even though it's called retic count in the circulation. An increased percentage of reticulocytosis occurs in the body, compensating for anemia. This increased retic count tells us that the patient has a healthy bone marrow. In pernicious anemia, there is no vitamin B12. The transport mechanism, there is no intrinsic factor. That person might be profoundly anemic, but low retics because the vital building block of the RBC is not present. The vitamin B12 is absent. Therefore, retics cannot be produced. This tells you if the body is able to correct the anemia. The example given earlier for me, both men were healthy until their blood loss. Two men with acute blood loss, healthy before they had acute blood loss. Both were able to correct their anemia. Not all patients can correct their anemia. 1 to 2% variation is normal in your red blood cell count and retic count. With someone who has a markedly increased reticulocytosis, this can cause a transiently increase in RDW. The young man with a femur fracture, you notice elevated retic count, and most likely he will have an increase in RDW due to marked increase in reticulocytosis. With anemia therapy, the retic should go up quickly and aggressively. You are giving that person the building blocks to correct anemia, whether it be folate, vitamin B12, or iron. When you order a lab test, you need to know what you are looking for. You need to be cost effective, and there are cost effective algorithms out there by Dr. Ferry, who's very, very good. And you want to order labs and you want to know the answers. When you order those labs, what answers will they give me? Retic count is one of the most valuable labs in helping us evaluate anemia, telling you whether if a patient has reticulocytosis, helping to correct the anemia, or reticulopenia, low retic count, the body is unable to correct anemia. For example, aplastic anemia, A mean none, plastic mean production of. Aplastic anemia, we see this when stem cells are not being produced. We have bone marrow suppression, and these can be due with chemotherapeutic agents or anemia of chronic disease. POIC, or poikilocytosis, under the red blood cell morphology, is the presence of abnormally shaped RBCs. POIC, same as poikilocytosis, a lot of people will say POIC, is not specific to any particular diagnosis, but rather usually noted with a significant hemolytic problem. For example, a woman comes in to see you who has increased perimenopausal bleeding with uterine fibroids, heavy bleeding, mild anemia, hemoglobin is 11, hematocrit is 33. She has developed a mild iron deficiency anemia. She's had heavy menses for the past 5 years. She might have a mention of, on her CBC, anocytosis reflected in the elevated RDW, abnormally shaped red blood cells. She might also have poikilocytosis. Why? Because her anemia is, she will not have a mention of poikilocytosis because her anemia is not that bad. Some with pernicious anemia, vitamin B12 deficiency with poikilocytosis is present. The hemoglobin is 5.8. Oftentimes, you might every once in a while see a patient come in with this. It is amazing that someone can be in an upright position with a hemoglobin that low, but persons can. That person with a profound B12 deficiency likely will have a report of poikilocytosis in the RBC morphology. You have a 42-year-old woman with a copper-containing IUD. She has an IUD called Paragard, which is a highly effective form of contraception. The copper-containing IUD is one of the most efficient contraceptives. However, Heavy menses occurs, and she correlated this with the insertion of an IUD 5 years ago. And again, copper-containing IUD causes heavy menses. She has a chief complaint of fatigue, weakness, and a history of gastric bypass more than 10 years ago. Her BMI was 57, and 10 years later, after the gastric bypass, she has a PMI of 34. She exercises and is vigilant about what she eats. She has hypertension. She's on lisinopril. With the history of gastric bypass, what gets bypassed in the duodenum? What gets bypassed? It is the duodenum. Why the duodenum? The duodenum is where we absorb most of the calories. So duodenum is where most of the calories get absorbed. What else gets absorbed at the level of the duodenum? It is all the nutrients, the iron, and many other nutrients. There are two major risk factors here for this patient for iron deficiency anemia. One is gastric bypass, and the other is heavy menses. We also realize that she is at risk for malabsorption of B12 and a number of other micronutrients. In fact, people who have undergone gastric bypass, these patients are routinely supplemented with many of these micronutrients. On physical exam, she has pallid conjunctiva, and she has a grade 2 out of 6 systolic murmur over the pericardium without radiation. Her conjunctiva will only be pale when the hemoglobin is less than 8. Conjunctiva pallor is a late and not early sign of anemia. This murmur has been noted on her exam before. We know because she has conjunctiva pallor that she must have a pretty profound anemia. As a result of that, hearing this murmur that has never been heard before on exam, let's fast forward and tell you once the anemia was corrected, the murmur went away. So what kind of murmur is this? This is a hemic murmur, H-E-M-I-C, is a systolic ejection murmur that is heard in profound anemia, dehydration, or thyroid toxicosis and fever. Anytime the heart rate is going to go up, but the blood is thinner or the heart is pumping more aggressively than it normally would, you will hear a hemic murmur. Her hemoglobin is 6.6. She has profoundly low hemoglobin, and her hematocrit is 21. This is more or less what her hemoglobin should be. Her RBC is similarly reduced at 2.7. What we have here is proportional reduction of hemoglobin, hematocrit, and RBC. This is obviously a very profound anemia. She is not in your office now. She has gone home, and now you have these results. Her total WBC is 4.4, which means 4,400 millimeters per cubed. What I mentioned before, that the RBC is the most abundant RBC, which is 2.7 million RBCs. When someone has a very profound anemia, it is important to take a look at the WBCs and see how well the person is doing with WBCs. She has a mild reduction in WBCs with mild leukopenia. The reason you want to look at the RBCs, WBCs, and platelet count is you want to wonder, is this problem a stem cell production or is it an RBC production? You would be inclined to think that this is not a stem cell. The patient has, because her WBCs are not depressed, and her platelet count is elevated. Her MCV is 65.5 by Weintraub classification anemia. That's a microcytic. MCHC is 30.5. She's also hypochromic, and MCH is 20. The MCHC and the MCH both look at the color and identify hyperchromic if both abnormal. We know that she has a microcytic hypochromic anemia, most common anemia in the world. Our RDW is 22.9. What does this tell us? That it is elevated above 15%. This tells us the new cells differ in size when compared to the older cells. This is one of the best indicators of an evolving microcytic or macrocytic anemia, and she has an evolving microcytic hypochromic anemia. Remember, a retic count is not a count, but rather a percentage of the total RBCs. This is reported to be 5% but corrected by the anemia 2.4%. Her body is attempting to make new RBCs but lacks the micronutrients to do so. Therefore, she has a slightly abnormal high reticulocytosis percentage, and she's doing pretty well given her profound anemia. Her RBC morphology is 3. That means she's hyperchromic. Her H&H was low enough. This triggered the lab technician to do a peripheral stain and actually look at her RBC. General rule is that this is not done in a less severe value. It was done in this case because she was so low. She had 3+ hypochromic pale cells. How do we know she already was hypochromic? What value? The MCH and MCHC. She has anocytosis. We already knew that, though, because of her RDW being elevated. She has marked POIC, and that's the varied shape. POIC will be noted in more severe anemias. She has platelets of 675,000, and what are normal are platelets for 150,000 to 400. Remember what was said before. You need to take a look at the RBC, WBC, and platelets. To say to yourselves, is this a stem cell problem? Obviously, she's having no problem with the stem cell because she is making a huge number of platelets. When you see this, this is thrombocytosis, which is an elevation of the platelet count. She has a fairly marked thrombocytosis. When you run into an elevated platelet count, you have to ask another question. Do you have a reactive thrombocytosis or do you have a clonal thrombocytosis? Clonal will be a problem with the body making too many platelets. Reactive is far more common. She has a reactive thrombocytosis. The reason you can say that is because, with a surety, because she has no evidence of previous elevated platelet counts. She has no splenomegaly. With clonal thrombosis, the patient would have splenomegaly. With reactive thrombocytosis, there was no evidence of a source. A profound anemia, infection, or inflammation. The patient has severe anemia. That is what we want to concentrate on here. You as a provider would operate that this is reactive thrombocytosis and no special intervention is needed. It's a microcytic hyperchromic anemia. What is the most common reason? Iron deficiency anemia. We also had in our history two major risk factors for heavy menses, and two major risk factors are heavy menses and gastric bypass. The patient's ferritin was 2 nanograms per ml, and the normal range is 10 to 300. This range is so great. Ferritin is highly specific to iron deficiency. Ferritin is reflective of iron stores. Here is something to keep in mind with the ferritin. When ferritin is 10, it looks technically normal. Here is one way of looking at it. If you think of ferritin as cans of iron on the shelf waiting to be used, you want your cupboard to be fairly full. When the ferritin is 10, there is really only 1 can of iron left, and if you use it, the cupboard is now bare. So what do you think? Do you think 10 is okay? No, it's not. It's not. This tells you there is 1 can of iron left. You really would rather see the ferritin maybe at about 30, which tells you there's a good cupboard full of iron there. This is highly sensitive, highly specific for iron deficiency. Her serum iron is 75, and the parameters are 30 to 160. This is a low sensitivity, low specificity test. Her iron is normal. Her ferritin is telling us the cupboard has been bare for forever. Why is her serum iron okay? This patient is taking an iron supplement. Remember, serum iron is a drug level. This is one way of thinking of it. For example, if you gave a patient 100 milligrams of Dilantin and 12 hours later you draw a Dilantin level, will that patient have a Dilantin level? Yes, they will because they just took Dilantin. So basically the patient only took one dose and waited a few days. And basically she metabolized the drug, and after it's metabolized, that level will go to 0. Iron is the same way. It is a drug level. What it is best reflective of is iron ingestion over the last 24 to 48 hours. What it is best reflective of is iron ingestion over the last 24 to 40 hours. Whether it is supplement, food, or whatever it will be, serum iron is unreliable, low sensitivity and specificity. Total iron binding capacity is elevated at 479. That is a better sensitivity and specificity as compared to the iron level. Well, also, general rules to stick to ferritin when you look at an order or change in iron deficiency anemia. What is going to go bad first? Ferritin is going to go bad first. As the iron stores are depleted, think of the cabinet filled with cans of iron, then the bone marrow will be iron depleted. This is the most sensitive and specific test for iron deficiency anemia, but it is seldom needed. I only bring it up if your patient had other problems and your patient needed to have a bone marrow biopsy done, and as a result of the bone marrow biopsy, it says there are no stainable iron. Then you will know why. Then the serum iron level will drop, so to keep that in mind. Again, iron is a drug level. RDW will go up when the newer cells are smaller and paler. Therefore, if you get a CBC with an early iron deficiency anemia, the first thing you might pick up is that this patient has elevated RDW. Total iron binding capacity will increase as open spots for open spots for iron binding. Then the hematocrit and hemoglobin will drop. Then the RBC indices become abnormal. The RDC indices are the MCV, MCHC, MCH. The RBC indices changes as the cells become small and pale. Why is it then that the indices are the last to change? And that is, all you need to remember is M stands for means. The M means mean. The average size, therefore, before the MCV will drop in iron deficiency anemia. A number of the normal cells have to age out and die off and be replaced by the microcytic cells. That's why we want to depend on the early warning signals like the elevated RDW. That will give us a heads up a little bit sooner than waiting for the indices to become abnormal. Say a patient also mentions he's had a 6-month history of restless leg syndrome. Could this be attributable to iron deficiency anemia? Remember, she's 42, she's never had restless leg before. Now her legs are hopping up and down, disturbing her sleep. Yes, one of the leading causes of iron deficiency anemia is the new onset restless leg syndrome in the adult population. Keep that in mind for one of your differentials. Because primary restless leg syndrome would be a patient coming into you and be like, my legs have hopped up and down like this my entire life. But it is getting worse as I get older. That is the history of a primary restless leg syndrome. Secondary restless leg is, I think I have this disease, and they talk about that they saw it on TV and it just started 6 months ago. I never had this before. Really keep that in mind. What about the patient of iron deficiency anemia? The patient needs iron plus B complex. Ferrous sulfate is one that is most commonly used. Ferrous gluconate is often said to be better tolerated, but the reason is that there is less iron per tablet. That is why it is better tolerated. Please avoid the use of enteric iron. Any med that is enteric coated releases beyond the duodenum to the jejunum. What is the best point in the GI tract for iron absorption? It is the duodenum. So our patient does not have the ability to absorb. She was treated with iron, parental iron. We need to keep this in mind to those who have undergone gastric bypass. As they age, the ability to absorb micronutrients through jejunum and the ileum might be impaired over time. She was treated with parental iron for two reasons. One is she does not have a functional jejunum and duodenum as a person who has an intact, as compared to a person who has an intact GI tract. Two, her iron deficiency anemia was such a profound degree of anemia. Let's push her gastric bypass to one side. The majority of people take oral iron. That there can be a possible, also, we need to teach patients about the possible chelation effect when iron is in the stomach with other meds. When iron is in the stomach with other meds, like metals or minerals, let's say this is a typical perimenopausal woman. She takes calcium supplement BID, and now she's going to be on an iron supplement BID. If she takes her calcium and her iron together, they will chelate. She will not benefit from either one of them. The iron in the stomach by itself, separated by other meds by at least 2 hours. So these patients need, if they're going to be iron, all other meds separated with at least 2 hours. This gets to be a little bit of a pain. BID iron is about as high as you should go. I know you can dose it. TID, the duodenum will not tolerate this big of a dose. When you get beyond BID, make sure doses are at least 6 hours apart. How long should you treat back to a healthy hemoglobin? That's about you want to treat to a healthy hemoglobin, and then you want to add 2 months. So the question would be is why the 2 months? Basically, you need to put those cans of iron back in storage. If you treat just to the healthy hemoglobin and not beyond that, what you will have done is corrected the blood, but not correct the low ferritin. Ferritin will be the last value to normalize because the body will utilize the iron as it is taking it in day to day, making the new RBC, and really start building up the stores again. Should we put people on routine iron supplements? Absolutely. If they've had gastric bypass. If not, no, you don't. For example, a woman in reproductive age, should you say to her, just go on iron supplements every day? No. And the reason for that is that no routine iron supplements, because iron is a potent oxidizing agent. And as a result, because it is potent oxidizing agent, it can, in theory, accelerate atherosclerosis and a number of harmful processes in the body. What about anticipated results with iron deficiency anemia treatment? For example, is the bone marrow responding to treatments? Check 6 days into the therapy and check the retic count. You are going to see a huge change in the hemoglobin or hematocrit. But if you see an increase in retics from 2.4% or 4 to 5, that tells you the body is replacing the red blood cells. If not actively losing blood, the hemoglobin every 3 weeks. The ferritin will normalize in 3 to 6 months. The ferritin will normalize in 3 to 6 months. So again, the ferritin will normalize in 3 to 6 months after the hemoglobin is normal. So that's it, folks. That's all that I have. And it's about 40 minutes. I hope that helps and it ties in the PowerPoint and the articles. And good luck.